Dear colleagues, today is my pleasure to welcome you to this ESC Heart Failure Symposium 2021, organized by Edwards Lifesciences on the management of heart failure patients with MR or TR, new guidelines and new transcatheter options. This is an intriguing topic because nowadays we see more and more heart failure patients, and these patients often have not only a ventricular problem, but also a valvular problem, which can be mitral regurgitation and or tricuspid regurgitation. And we're going to talk about that. How do we treat optimally these patients? We have two excellent speakers. We have Stephan von Bardeleben from Germany, and we have Michael Böhm from Germany. Stephan is working in the transcatheter heart valve space, and Michael Böhm is an expert in heart failure treatments. So without further delay, I'd like to introduce Stephan von Bardeleben to provide his lecture for us, Differentiated Technologies for the Successful Treatment of MR and TR Patients. Stephan, please.
Thank you, Jeroen, for the introduction. And it's my pleasure to highlight now the differentiated technologies available for the successful treatment of mitral regurgitation and tricuspid regurgitation patients. These are my conflicts of interest. The Pascal platform for both mitral regurgitation and tricuspid regurgitation consists of some unique specifics of the medical device, which is a central spacer that fills a gap between leaflets. It's an elongation feature that allows to correct the position and to free yourself from any entanglement of the chordal or subvalvular structures. A nitinol design that is very adaptive and is able to cover stress situations on the leaflets and transform them into the device, as well as the ability to independently accentuate the clasps to catch both leaflets, even in very difficult prolapse or in heart failure in functional tethering. The Pascal platform for MR has been tested and showed sustained MR reduction, and also, which is unique to only 3 studies worldwide, a positive LV remodeling. The CLASP study showed sustained MR reduction at 2 years, and what is noticeable is that the standard efficacy profile, gaining mild to moderate as maximum, including mild and non-trace, in almost 100% of the cases. If we take a very high efficacy threshold of only accepting non-trace or mild, we also achieve this in almost 80% of the cases in this series of 124 patients. What is also very important is that a positive LV remodeling was seen in those patients. So coming from a left ventricular end-diastolic volume of 181 cc, which was non-indexed, but which covers the experience of previous TEER, we could see that both at 30 days, significant reduction was seen, as well as a more pronounced reduction in LV volumes over 1 and 2 years. The Pascal platform experience has been extended also to commercially treated MR patients. I'm happy to show you here the experience of more than 2,000 patients where the same data was reproduced in a larger series. And you can see that in 75%, the high efficacy goal of MR1 plus or less was achieved. In a small series of 103 mitral valve repair patients from the Munich group, we could also show that MR reduction is possible both with the classic 10 millimeter wide Pascal system, but also with the Pascal ACE implant system on the right-hand side. So the Pascal platform for mitral valve treatment showed Pascal MR class study 2-year outcomes, which maintain sustainable and very durable significant MR reduction with a first evidence of LV reverse remodelings and signs of improvements in functional status. The series of about 100 patients could be extended to 2,000 patients in a real-world and single-center experience, showing that the high rates of MR 0 to 1 plus can be achieved in real world after a very short learning curve. that the procedural time decreased actually below 60 minutes for FMR and DMR, and that these findings were absolutely consistent with the previous class study. Coming to the tricuspid valve, the first device that entered the market in 2015-16 was the Cardioband tricuspid valve reconstruction system. We're happy to treat the second patient worldwide on the tricuspid valve. It was a surgical approach which restored the valve and the annulus geometry to a more functional state and adding cooptation to the tricuspid leaflets. So this system allowed an adjustable beating heart implantation with annular reduction that could be done on a beating heart scheme in a closed chest model. And on the right-hand side, you could see that live echocardiography throughout the procedure showed the annular adjustment results in real time. The annular diameter reductions were significant, as well as sustained from discharge 30 days over 2 years. TR reduction was maintained, again with the goals of mild to moderate in about 72% of the patients. Cardioband tricuspid system also showed clinical benefits in approximately 80% of the cases, as well as a significant increase in the now in heart failure, very well accepted Kansas score. And you can also see that this improvement was by 18 points, which is highly significant. Coming back to the Pascal platform for TR, we could see that the Pascal repair system at 1 year was also able to reduce TR in a significant manner. And again, here accepting 1+, 2+, and 3+, we could see that 93% of the cases achieved this goal. A 1+ to 2+ reduction, so up to moderate in a 5-grade scale, unlike the mitral valve, was achieved here in 86% of the patients. Astonishingly high was the safety of this approach, and you can see that the death rate intra-hospital was 0% in the beginning, up to approximately 20-30 days, and reaching a level of a death rate of only 6.7% at 1 year, which is lower than the intra-hospital mortality of isolated TR treatment and surgery. The combined endpoint of death and heart failure was reached in only 23.5% at 1 year, which is significantly lower than what we see actually in medically treated patients. We could also show that there was a remodeling on the annular diameter by a leaflet therapy, as seen on the right-hand side from 4.7 centimeter, which is guideline concordant to surgical thresholds, and a reduction to 40 millimeters at 12 months, which was also sustained. The Pascal repair system fared well with a very huge decrease in the New York Heart Association class to the better, with patients being asymptomatic in the lower part, as you can see, and achieving a large proportion of the patients, about 90% in New York Heart Association class 1 or 2. The 6-minute walk distance was significant and was achieved in approximately an increase in 53 meters already at 30 days, which was then pronounced, even more pronounced at 1 year with 72 meters. And this is a classical finding that we see in tricuspid treatment, that the decrease in central venous pressure improves diuresis and also the response to medication and increases cardiac output in those patients. I thank you very much for the kind attention, and I now hand over to the next presentation before we go into the discussion. Thank you very much from the Heart Valve Center at the University of Medicine in Meinz, Germany.
Ladies and gentlemen, dear colleagues, it's my task to discuss with you how we can support heart failure treatment by valve therapy. So first of all, that is what heart failure is all about. We are talking about heart failure with reduced ejection fraction, and you can see the scheme that we are dealing with progressive remodeling, which is affected by, of course, a trigger like MI, but of comorbidities and neuroendocrine activation. So the question is, from when do we get mitral valve incompetence due to complete remodeling of the ventricle? And in particular, when that is repaired, from where is it reversible? And is it possible to find an improvement only with drugs? So now that is the mainstay of heart failure treatments. And here you can see this is usually neuroendocrine antagonists, and they are all involved in remodeling. And so the question is of how complete can we reverse this by inhibiting these pathways with antagonists like ACE inhibitors and beta blockers. And there is an old study showing this. And you can see here the placebo groups, which is this orange one, and the placebo group, which is the red one. And what you can see, that appears to be possible with beta blockers, but not always, because with ACE inhibitors, you can hold remodeling, but you will be not able to produce de-remodeling. So they are not as efficacious as we sometimes think. However, we have new trials like the ACE inhibitors, which now are substituted by the ARNI with the neprilysin inhibition and the SGLT2 inhibitors. And with SGLT2, the remodeling is there, but not so strong, but it is quite strong with the ARNI. You can see here ejection fraction and systolic diastolic volumes and atrial volumes, so all the targets for mitral valves. And you can see here the line of neutrality, and indeed, after application for 3 months with sacubitril valsartan, about 70 to 80% of the patients have de-remodeling. And indeed, if you look at functional mitral regurgitation, and that is a very interesting study from Korea, you can see that some people have no change. And some people do improve. So waiting for 3 months is okay, but you can also see that 3 months, then the decision be taken for a mitral valve intervention, because otherwise you lose 55% of patients who still have significant mitral regurgitation and should be treated with mitral valve incompetence. And if that is done, and this is what you have seen before, and you know that this is a co-ed study with this huge effect on the number needed and slow number needed of treats concerning hospitalization for heart failure and all-cause deaths. Now you might suggest, of course, how big is the effect? And indeed, mitral clip, and this is here the Greg Stone study, produces at least as an effect as big as with these trials. And this is not alone. This is as add-on therapy for heart failure treatments, because you can see, and these are the data from COAP, these people were already on almost best medical treatment comparable to drug studies, which are now contemporaries. However, what should not be forgotten is the right ventricle. You can see here the right ventricle is following the left ventricle and produces tricuspid regurgitation. And you can see that almost a significant number of patients after mitral valve repair, 50%, remain with tricuspid regurgitation, and the amount of this right heart valve disease is predictive of survival, as is, by the way, right ventricular function, which is more predictive than ejection fraction. And I have here indeed chosen an old study to show that this is not a new story, that is quite known. So therefore, taking also the right valve into focus in heart failure might improve outcomes. So these are patients here with mitral incompetence, and you can see that those patients who underwent a successful tricuspid repair, they do much better than controls. So now, when should this be done? I mean, this is the hypothesis here. If the remodeling process is underway, of course, in addition to medical treatment, there should be effective treatment of valve disease. However, one should not wait too long, because here we might add in a stage where we are beyond reversibility. And indeed, there are old data, several of them, and this is a new study among many, where you can see that those people who have a low EF and high pulmonary pressures, they initially drop with their Wood units, but then they go up again. And doing it earlier, then of course you have an improvement and no further increase, indicating that there is an optimal time point and there is no way to defer treatment too late, otherwise you will not have the right success. And indeed here you can see it. This is the survival in patients with a good EF, low EF, and then big, with high pulmonary pressures, low, and the combination. Now we have the guidelines, which means optical medical treatment, but also looking at the valves, and this could be in the guideline in this place because that is for the subgroup, this mitral regurgitation, and this should be done then. So taken together, progressive remodeling is a pathophysiological basis for a successful heart failure therapy, and that, of course, should involve a mitral valve correction and tricuspid valve correction on optimal medical treatment. Even with the ARNI, 50% of mitral incompetence persists, and 30% might also have significant mitral regurgitation. So right ventricular function determines outcome, and all these issues should be addressed by successful valve and drug treatment. And please make sure that you are not too late. Thank you very much for your attention.
Well, thanks very much. These were two excellent talks. I really enjoyed it both, and they're so complementary. The one really complements exactly to the other one. I think we have all speakers ready here with us. Is Michael Böhm also on? Michael, are you on?
Yes, I'm here.
At the last minute, you made it. Hey, Michael, that was a fantastic talk. And I just like to discuss with you briefly. You indicated very clearly ARNI and SGLT2 inhibitors, very successful drugs. At what stage do you use them in your heart failure patients?
I mean, we have now discussed the new guidelines yesterday. Usually they should be used very early on, and then 3 to 6 months should be waited until we have the effect on de-remodeling. So they are now in the new guideline as discussed yesterday, the first line drugs to start with. If a patient, and that is about 80% of the patients, are already on an ACE inhibitor, they should be exchanged for an ARNI, and SGLT2 inhibitors do not have any limitation because they have only small effects on blood pressure, and they should be in the first line of any heart failure drugs. I think that is now common sense.
Excellent. That's a big step forward, actually, that we're making now.
Absolutely.
Another question that I wanted to ask you, in your practice, in your daily practice, focusing on heart failure and severe MR, you start with GDMT, as we all do, but before you reach out to mitral valve repair and maybe tricuspid valve repair, do you first go all the way to maximize the dose of GDMT, or do you already earlier start with mitral valve repair?
So the point is, one should not be too late. So usually we wait before we have it 3 to 6 months when all drugs are in. We had a discussion also on this meeting 2 days ago on the dose-response relationship, and the dose-response relationship is very weak. So the small doses work too. The big differences in outcome usually are related to the fact that there are reasons not to give the drugs, and that are stronger than the close dose relationship on drugs. That is simply shown when you look at the data of registries and also on the randomized data, for instance, like in the HEAL and in the ATLAS studies. So the true relationship of dose response is weak. So small doses work as well. So it's more the number of drugs who are in. So don't wait to uptitrate all the drugs to the maximum dose, as they will anyway not be tolerated in the highest dose.
Now, that's a very important statement that you put forward, because if we wait too long, the further remodeling will take place, both in the LV and in the RV, which will eventually probably put at risk the best treatment with transcatheter. So let me switch here to Stephan. And Stephan, your talk was superb also. So based on COAPT and CLASP studies in which DMT and transcatheter mitral valve repair were combined, how do you see the integration in your practice between GDMT and transcatheter mitral valve repair? How do you do that in the daily practice?
I think the unloading is very important. And what we said is not only true for the time course of initiating new drug therapy and the combination of it, but also to take into regard the remodeling and the size of the ventricle per individual patient. And as Michael put it out nicely, the combination of more therapies may be more effective than up-titrating only a single therapy or a double therapy. So what we have seen in comparison to COAPT, where we did not see remodeling anymore, or mitral FR, especially in the large ventricle group. So if you had 130, 135 cc per meter square, patients did not remodel. The latest trials, CLASP 2F, and also the EXPAND trial, actually these trials showed that we have remodeling if the patients have only 100 or below cc per meter square. This corresponds nicely to the 180 cc's unindexed that I showed you in my presentation. Also, the reduction plays a role. So in our center, we would, of course, take guideline-directed medical therapy, take the combination, and we see actually with the added therapy after 1 month, 3 months of valve therapy, if under the initiation of ARNIs and SGLT2, we still see severe mitral regurgitation, then the addition of valve therapy really brings a progression in positive remodeling. So smaller ventricles, better functional status, better walking distance, better Kansas City scores for quality of life. And we also know from COAPT that the 1 month results of an improvement in the Kansas score predicts 2-year outcome of the patient. So mortality decreases. If your patient says, my combination of GDMT and valve therapy has improved my life at 1 month, then I will also survive at 2 years. And this is a hard endpoint, mortality.
Yeah, that's very good arguments. But also you raise the awareness of what is very important for the patient is the symptomatic improvement. So both living longer, but if you ask the patient what is really mattering to you, then they always say, well, the symptom relief is very important. Another question that I had to you is the recent studies actually have shown that TR is associated with poor patient outcomes, and that transcatheter tricuspid valve repair can significantly mitigate these outcomes. So based on this, same question as on the left, what is the right moment to treat TR with transcatheter tricuspid valve repair?
First of all, we have the possibility, and I think an improvement is only seen in approximately 30 to 35% of the cases after mitral treatment. But having the possibility of transcatheter staged interventions, this is a huge superiority to actually surgical approaches. The surgeon who opens the chest has to treat everything. So he treats also the possible responders. He will treat 30% of the patients that would have also reacted on a pure mitral repair. In transcatheter cardiology, we're able to actually wait for GDMT effects for 1 or 3 months. And I would also wait for 1 or up to 3 months for the effect of the mitral repair, which improves tricuspid regurgitation, especially in the group of moderate to severe. It will not improve actually torrential or massive regurgitation. There you have to additionally treat the tricuspid. And we know that the hazard ratio is between 1.8 to 2.7 for mortality if you have a persistent TR or a severe, massive or torrential TR at baseline. These patients really die with a number double as high than those who are also then treated. And we know from the non-randomized but propensity score match data from Teramasu from the TRIVALVE registry that actually if you treat both, you fare better than for single therapy alone. And I think this is an important message. And the data came from the US and also from your center.
Yeah, I think this is a very good point that we need to focus on both valves. But I also like what you put forward is the staging. This treatment gives us actually, this transcatheter approach gives us the possibility to first evaluate what's the response to this, and then we shift to the other one. Now, let me just ask to both of you a couple of issues. So first I'm going to ask you, Michael, given everything we discussed today, how do you foresee what is going to be the implementation of the new ESC heart failure guideline recommendation regarding integration of GDMT and transcatheter mitral valve therapy. We spoke about it already a little bit. So give us an idea, how are we going to integrate those two?
I think the guideline now for the first time really make a focus on the mitral valve intervention. However, I'm not supposed to talk about that because ESC, as you know, has disclosed to discuss the guidelines, although they were presented. So that was a little bit strange. I was in the meeting, so there was not one word about the valve interventions of the guidelines. This will be finally presented at the ESC meeting in September. However,
give us a peek review. Let's say, how would you do it?
I would definitely do it, and we had some, of course, discussions in the highlights sessions yesterday about medical therapy and interventions in general. It can be CRT, it can be ICD, but also valve interventions. So the consensus was that after 3 to 6 months, one should go ahead with these interventions in order not to wait too long. But also to leave the de-remodeling process going ahead with the guideline-directed medications. And there was a nice discussion yesterday that with the ARNI, there is the strongest de-remodeling effect. So if this drug is, and in many patients it is already in, and there is significant mitral valve disease after maybe 3 to 6 months, then I think we should go ahead. Not to miss the time point where de-remodeling by the valve intervention is missed.
Perfect. So it really becomes an integrated approach. So Stephan, last short question to you. In 2021, what do you consider the right moment for transcatheter tricuspid valve therapy in severe heart failure patients? Very short, last comment from your side, please.
Absolutely. Thank you very much for this opportunity. I think it has already been mentioned. We should treat the patient early enough that his absolute volume size is not too large. We learned this from surgery, also not more than 7 centimeters diameter. The effect is much reduced. We still have an effect on PA pressure. We still have an effect on quality of life. We don't have to miss that. This has already been shown in the Euro SMR registry. So it's not only the COAPT patient, I have to say that, but in COAPT-like patients or in indexed ventricles below 100 cc per meter square and guideline-directed stable medication that has not yet to be maximized, but has to be a combination of therapies after a waiting period of, in my opinion, 1 to 3 months, not to come too late. You should add, in a persistent, symptomatic, severe MR situation, you should add a transcatheter mitral valve repair to optimize remodeling and the positive effect on outcome for those patients. And I think this has been shown nicely. Individual single cases can be done at the border zones because they will still benefit from ability to lie flat, ability to have less dyspnea. New York Heart Association change is also a very important clinical factor, as is the quality of life score. This would be my final remarks for this. But to consider mitral valve repair is the first important movement, and to refer to a valve center level 1 is also very important in the heart team. That would be my remarks.
Great comment, as always. Dear colleagues, we see in our practice more and more patients with heart failure and secondary MR and TR. Today, we learned a lot from these two experts. We need to treat early, start GMT, including ARNI and SGLT2 inhibitors at an early stage to support the LV function and to prevent further remodeling. And likewise, we need to treat severe MR earlier using the transcatheter valve therapies. And also we realized that concomitant severe TR needs early treatment as well. In 2021, we now have the medication and we have excellent transcatheter valve therapies to give the best treatment to our heart failure patients. I thank again both speakers and Edwards Lifesciences for bringing together this excellent symposium. Thank you very much.